In this lecture, we're going to take a look at the first part of the cellular adaptations in injury. There is a section at the very end on the second part that deals with aging, but we're really looking at cellular responses to stress and injury. So first, we're going to really focus on adaptation, but we need to understand what the difference is between adaptation and injury. So this image helps somewhat. I wouldn't say it's the best thing going, but it is what is in your textbook, which is why I pulled it forward. So you have a normal cell that's in homeostasis. Remember, we're dealing with cellular issues here because all disease begins at the cellular process. So what's happening to the cells, whether it be cells of the liver, cells of the heart, muscle cells, any type of cells, epithelial cells. We take a normal cell that's in homeostasis and something happens to it. An increase in demand, stress. By stress we can mean any kind of chemical, environmental, pressure, any sort of effect on the cell that doesn't cause it to be destroyed or injured, but actually causes a change in the cell. Adaptations are changes in cells that are made in response to these various things. The changes in adaptation are generally changes in the number of cells, they may divide, changes in the size of the cell, they may get larger or smaller, or the type of cell may change. So that's really what we deal with adaptations. And coming into that, we also look a little bit at, and you see I've got it listed a little bit down here, that some of the responses are not the change in number, size, or type, but rather things start to accumulate in cells. They still deal with adaptation of the cell, it's not actually injury. In our diagram here, you see the normal cell with stress or increased demand will adapt, and if it's injurious stimulus, then we have cell injury. This is probably where I have a little bit of an issue with how it's laid out. There are definitely some things that cause cells to adapt that we would kind of consider to be somewhat injurious. So there's a little bit of a gray area with that. For instance, if you break a bone and put the bone, say it's the arm, and you put it in a cast, well, that arm that's in the cast will start to atrophy. There was injury, not directly to the cells that are shrinking, say not directly to the skeletal muscle cells that shrink, but there was injury to the area, the bone, which caused it to be put in a cast, and so those cells may shrink. Likewise, the opposite arm may actually enlarge a little bit because it's being used more. After that healing process is taking place, you remove the cast and the arms will come back into more or less normal size, and some will shrink and some will enlarge a little bit in terms of the skeletal muscle. So the term injury is a little bit vague. Direct injury to a cell causes cell injury, but indirect injury can cause adaptation, I guess is kind of what I'm saying. So it's a little bit gray right through here. Either way, note this, what's here is an adaptation can turn to cell injury. So if the stress, the demand, the accumulation within the cell goes on long enough, we can have cell injury. And you'll see that then that injury can be things that can lead to cell death or damage that's to the point of the cell that is no longer reversible. And apoptosis is in here, and we'll talk about that more so in the second lecture. That's a far more normal process, a normal response. This is an abnormal response, but again, that's more cell injury. We're going to focus first here on the concepts of adaptations. So how is it that the cells know when they need to adapt? So what's really telling it what to do? So there's a stress on the cell. Why is it going to change? Well, that's really all happening at the genetic level, and we will be looking at genetics. We're going to do thyroid, and then we'll look at genetics. So I threw that a little bit later on, so we're just going to do a very general conversation here about these housekeeping genes and the gene function. But within cells, within the nucleus of cells, you have your DNA, and your DNA are containing the messages that are necessary for what makes that cell specific and what makes all cells part of who you are. And so in every cell you have what are referred to as housekeeping genes. These genes maintain the normal functions of cell, such as making sure there are the right number of cellular organelles, make sure that the cell membrane stays in structure, make sure the lysosomes do their job to get rid of the old parts of the cell, and you recycle very efficiently. And so housekeeping genes do that function. Then you have genes that are specific for the particular cell. Those specific cells are things that are unique to that, or those specific genes rather, are for the specific functions of a particular cell. For instance, the cells in the adrenal gland produce epinephrine. So your heart does not produce epinephrine, it responds to it. Your cardiac muscle cells contract. So inside a cardiac muscle cell, you'll find these high numbers of mitochondria. So you've got genes to code for the proteins to make lots and lots of mitochondria in the cardiac muscle cells. Whereas in the adrenal medulla, you have genes that are coding for the formation of cells that will secrete the epinephrine. So those are specific function genes. So in general, when adaptations occur, it's the specific functional genes that are affected and less so the housekeeping genes. So in those adaptations, you might say a reduction in certain, if there's some stress on the adrenal medulla, the amount of epinephrine produced might drop, but the cell membranes will stay intact, and in general, the function of the cell will stay alive. So that's the point of the adaptation, that you've got two different sets of genes. It is the specific function genes that are more likely to be involved in being reduced or lessening in an adaptation. Housekeeping genes will keep that cell alive. Now, I mentioned here some intracellular accumulations, calcifications. This is something else that can happen in adaptation. And going forward, we can look at a little more categories of what we mean by intracellular accumulations. What we're really talking about is the buildup of substances in the cell that should not be there. So these are things that might be normal. You'll see that we've got three conditions listed here in which the substances themselves are normal, but the amounts are abnormal. So fatty liver disease refers to abnormal accumulations of fats in the liver, and they're intracellular accumulations. So you should have some fat in your cells, you need some lipids in there, but you have too much, you get fatty liver disease. So that's still considered an adaptation, and it's a stress response. And by stress, I mean something is applying pressure and demands, and it may be related to diet, it may be related to metabolism, but those affect the function of the liver cells. They're not dead yet, they just have substances accumulating in them. Von Guericke's disease is a genetic disease. It's a glycogen storage disease. Remember what glycogen is? Glycogen is the stored form of glucose. And so this is a disease that really is involved and it affects metabolism. Glycogen starts to accumulate in the liver and kidney, and you can't get it out, and we'll talk more about that disease later on. But what you have is glycogen should be stored in cells of the liver, and you should be able to pull it out and use it when you need stored glucose. In von Guericke's disease, they get in, it's stored, and you can't get it out, so it starts to accumulate in greater amounts. And then Tay-Sachs disease is another disease we'll look at in the genetics chapter, but this is also a lipid accumulations, but this is primarily in the brain and other tissues that causes both motor and mental damage. This is a congenital condition, and children are born with this disease, and very, very, very few live beyond the age of 3 and do not have normal mental or motor development. So these are, again, abnormal substances. The cells themselves do not immediately die. If we go back to our diagram, they're still in an adaptation. They may proceed to cell injury and then necrosis and death, but they may not necessarily. Then you have some what we refer to as abnormal endogenous. These are abnormal things that are not normally something we accumulate in the cell, but they do come in from an internal environment. So jaundice is an example of an intracellular accumulation of something abnormal. So jaundice has to do with the when you break down hemoglobin, and you start to have the accumulation of the pigment from the hemoglobin, and it causes your tissue to start to appear, your skin and eyes, and to start to appear yellow. That is an endogenous substance because it comes from the body, but it's accumulating abnormally. It should not ever accumulate. It should be a waste product. So it's an indication the liver is not processing correctly. And then you have abnormal exogenous components. Coal dust is what I listed there. There are all kinds of things from the environment, asbestos and other things that could start to accumulate in the cell. It's usually we're thinking of environmental substances, but another abnormal exogenous substance that can accumulate is the pigments from things like tattoos. So that's why they're there, and that is considered abnormal. It does cause an adaptation to the cell. In most cases, as many of you may know, if you have a tattoo, it does not actually cause cell injury and death to tissue, although sometimes there are infections and things that can occur. You also have what is referred to as pathologic calcifications. And so your author puts this right here in this section. I kind of would probably put it a little closer to a cellular injury than an adaptation, but we'll cover it here in the sequence and where the author or Porth has put this. So again, calcifications are accumulations of calcium. It can also be magnesium, iron, or some other minerals, but primarily we're usually dealing with calcium. And so we actually have our first real hint at a electrolyte imbalance. Calcium is actually one of our electrolytes, and so pathologic calcifications, whether they're dystrophic or metastatic, are both dealing with the hypercalcemic state. Hypercalcemia is high levels of calcium. So calcium, if it is dystrophic, calcium salts will deposit in some tissue that's already been injured. It may already be dead or dying. And dystrophic calcifications are visible to the naked eye. Now, when I say visible to the naked eye, I don't mean, you may have calcifications on an aortic valve that'll only be visible if you actually look at the valve. You can't see it from the outside of the body, obviously. But if I were to look at that tissue, I wouldn't need a microscope to see it. Dystrophic calcifications can be seen outside. And then, sorry, my phone rings. Well, sometimes I'm doing lectures. You just have to kind of go with that. And then you have metastatic calcifications. In metastatic calcifications, you have hypercalcemia, and it might even be high levels of phosphate, and it deposits calcium and phosphorus in blood vessels, in lung tissue, and particularly vulnerable in the tubules of the nephrons. So in this case, we are looking more at a condition that is cellular injury that leads to cell death. So again, this is really metastatic, is hypercalcemia or high levels of calcium, and probably also high levels of phosphate depositing in the blood vessels, in lung tissues, and in the tubules of the nephrons. So dystrophic and metastatic are similar, but dystrophic is already accumulating in areas where the tissue is already damaged. Metastatic is causing its own damage all on its own. All right, looking just quickly then at your cellular adaptations. Your book does a really nice job of laying these all out, so I'm not going to spend a lot of time in this lecture going through them, but these are the adaptation categories. So the first one is atrophy, a decrease in cell size, all kinds of things that can cause atrophy, simple disuse. If you've been exercising and then suddenly you stop, your muscle cells will start to shrink. So they get smaller. They don't necessarily die. They just get smaller. Certain loss of hormones. Women who go through menopause will see the atrophy of the uterus. The ovaries will start to shrink. That's due to lack of estrogen production. Lack of nutrients or lack of blood flow can cause atrophy to occur, and just aging in general. And your manifestations of atrophy are pretty straightforward. With lack of size of muscle cells, the strength and force of contraction will shrink. As cells shrink, their functions diminish. And so again, it may not be total loss. Even in during menopause, you may still have some low levels of hormone production from the ovarian cells, even though they've shrunk dramatically. But you're certainly not going to see a woman postmenopausal who's going to see the normal functions of the thickening of the uterine wall and the menstruation process. That all will go away. So a lot of the function diminishes or drops off dramatically. And be careful with atrophy. When we use the term atrophy, we're really talking about cellular atrophy, not organ atrophy. If an entire organ shrinks, that's in something entirely different and often is not reversible. Arguably, things like menopause are not terribly reversible either, although with an increase in hormones at certain points in time, you can bring those cells back up to functioning. We've certainly seen that happen. If you watch the media and the 60 and 70-year-old woman having babies. Hypertrophy is an increase in cell size, And we can look at hypertrophy as really a more positive or physiologic process or a pathologic process. And so in a more physiologic process, we're looking at normal increase in cell size, say from exercising muscles and so forth. And then pathologic conditions can be things that enlarge, that are abnormal, from abnormal hormone production. You can have some cellular or some cardiac issues in which the heart enlarges abnormally. Like an athlete can have physiologic increase in cardiac muscles, and it is uniform across the heart. It enlarges, both atria, both ventricles enlarge equally, and the heart is functioning extremely well. But there is pathologic enlargement of the cardiac muscles, in which part enlarges and part does not. And in those cases, what you have is a dysfunction. So some hypertrophy is adaptive, and by adaptive, what we're really talking about is a case in which some injury has happened in some area. And for instance, if you take an adaptive and compensatory are very similar, you'll have a kidney removed and the other kidney will enlarge. That's an adaptive hypertrophy. Then you have hyperplasia, and hyperplasia is an increase in cell number. Again, some is physiologic and normal, can be an increase in hormone production as it would occur, say, during pregnancy. Breast enlargement, uterine enlargement occur during pregnancy. That's a normal process. A wound healing arguably is a normal process. The wound itself was not normal, but the increase in growth of new cells in the healing process, that can be a normal process. And then compensatory physiologic hyperplasia is what actually happens. Say if I were to remove a portion of the liver, you would do a partial liver transplant and donate a lobe or portion of your liver. The liver will increase in its size, but not because the cells got larger, but because the cells divided. So kidneys get big through hypertrophy. If you remove one kidney, you donate a kidney, your other kidney will enlarge in the compensatory hypertrophic process. And again, we still call that pathologic because it's not normal to have only one kidney. Even if you've donated it, it's not that it was diseased, but it's still not a normal process. And then in the compensatory, the terminology is a little different. The author uses the term physiologic compensatory. Portion of the liver is removed and you're increasing it. What they consider pathologic or abnormal hyperplasia is almost always linked to excessive hormones that cause there to be an increase in the number of cells. That can occur in things like endometrial hyperplasia. Warts might be an example of something in which you have a pathologic or abnormal hormone production that causes wart growth. Metaplasia is a change in the cell type. That's where you're going from, and this is really still almost exclusively within epithelial tissue. You really don't see metaplasia occurring certainly not in muscle tissue. You will not see skeletal muscle suddenly become smooth muscle. You will not see cardiac muscle suddenly become skeletal muscle. The muscle types don't change. In metaplasia, you have a change in cell type where you might go from simple squamous to stratified squamous, or from stratified squamous to simple squamous. So depending upon what the stimulus is with metaplasia. So this usually occurs in older only in adult cell types. Metaplasia is actually never a normal or physiologic process. We don't normally see that change unless there's some abnormal stimulus. One of the most common areas of change would be along the trachea, which should be pseudostratified ciliated columnar epithelia, and smoking will turn it into stratified squamous epithelium. So that's a common place. You can see that happening sometimes along the esophagus with acid reflux conditions. That acid gets in there and changes the type of tissue that lines the esophagus. So those are two common areas where you'll see metaplasia. Cell types change. It's epithelial cell changing from one type to another, still within epithelial. You don't see connective tissue changing, muscle changing, and so forth. Neurons are neurons. And then you have dysplasia. Dysplasia is where individual cells of a specific tissue vary in how they change. So some change to stratified, some change to simple, some are become columnar, and they're all over the place, and so they start to look kind of like an abnormal mess. And so dysplasia is often considered a precancerous state. And so this is particularly abnormal. It's still possible to be reversible because we're still in cellular adaptations. But this one is in terms of the, abnormal. The woman goes in to have a pap smear done and she's told she has an abnormal pap. It's not cancerous yet, but it's abnormal. It's dysplasia that's likely occurring there. These cells tend to start to break away easier. They're not going to hold together like a normal tissue would. So these are your cellular adaptations. I went through them really fast, I know, but go through the book and read through the sections of the book. It's only a couple of pages, but it does a nice job of laying out the characteristics of each of the cellular adaptations. And then cell injury will be what we look at with part 2, so I'm going to stop here.